I'm going to go ahead and call the meeting to order. And this is an educational session, and it's intended to really spend some time with Charlie, epidemiologist. I really appreciate Charlie being here to help us more understand what we're dealing with. And good morning, Karen.
Good morning. Can I do a quick announcement before we get started?
Sure, why not?
Sure. So I wanted to let everyone know that our staff epidemiologist, Carlin Porter, went out on maternity leave on, I think, March 13th, maybe. And we just learned that she had her little baby boy on Sunday. So it's really great news for her and her family, and super excited for them. Healthy, everyone's healthy, and so it's really just a great thing to think about that joy coming into the world, and happiness for her and her husband and their extended family, because Carlin went out on maternity leave on March 13th, we knew that we needed to have some epidemiological guidance for our community, and hired Charlie on contract to do this work for us. And we're really happy that he was able to come in on contract part-time to be able to guide some of our strategy, and to be able to provide our local data in relation to the state data. So I just wanted to introduce him as well and thank him for all of the work he's put into this. He has another job, and he's been balancing that with doing this modeling for us. So wanted to take the opportunity to share that with you all in the community. And then I just wanted to acknowledge, because I know there's a lot of people on the community on this call, that, you know, the Board of Health is a volunteer board, and they are doing a lot of work, you know, on their own time to be able to help guide the community. And I just wanted to thank the board publicly for volunteering really your efforts to get us into new spaces around this effort. So with that, I'll turn it back over to you, Marky.
Thank you very, very much, Karen. And I echo all the thanks. This board has been working very, 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 very tirelessly. I know you're doing a lot of reading. I spend a lot of time on the CDPHE website. And if you haven't been on it, get on the CDPHE website. And that's Colorado Department of, what is it, Health?
Public Health and Environment.
CDPHE, come on. And Environment, I couldn't figure out what the E was. And they have links right to all of the mandates and what the criteria by business that's already been posted. It came up on Monday afternoon. We'll talk a lot about that on Thursday. And I know some of you wanted to get into a conversation today about board responsibilities and scope of discussion and decision making. We're going to hold off on that on Thursday, because we should be conducting that discussion at a board meeting and not an educational session. So with that, I'm going to turn it over to Charlie. Charlie, you're going to have to tell us a little bit about yourself, and then continue with your educational session.
Sure. And Karen, did you have anything else you wanted to say on a lead in?
I think that what Charlie's put together, again, is localized data to really look at what has been happening here. We know that the community, Pickens County community, has done an incredible job at really suppressing the transmission of SARS-CoV-2 throughout the community. That we've seen with some of the sort of more subjective suppression data, like from Google and other sites, that we talked about this the other time, that we've received an A within the community. And because the community's done such a fantastic job at really limiting and adhering to the social distance and public health order, we have a lot of really great indicators that show that as a community, we're ready to start to move into our next phase. And so it really is a thanks to the community that has allowed us to have the time to build the infrastructure that we need, whether it's the box it in strategy or looking at this consumer protection program that we're trying to work through with businesses and really have a robust guidance for the community and for businesses to be able to open up slowly and safely in the next few weeks. This is a really great place for us to be, and we have to be super cautious in how we start to lift the public health order, ease out of that in phased steps, allowing the data to guide our strategy. And I think about what our guiding principles are in public health, the guiding principles that the public health team crafted as this new department was developed less than, I guess, well, about 3 years ago. And one of the guiding values that we have is really to have data-informed decision-making. And that can be both qualitative and quantitative data that we're using to drive the decisions that we all want to think through. And so from a public health standpoint and from a values standpoint, we really want data to allow us to better understand what's happening at a local level. Another value that I just want to elevate and bring forth is our equity value, and that we really want to ensure that the most marginalized populations in our community are the most protected, recognizing that there are those that are more at risk because of high levels of exposure or because of pre-existing conditions or other demographic criteria that might make them more at risk for getting COVID-19. And as we start to move into a new stage with the box it in strategy, we really need to ensure that we're thinking about those populations and really making sure that we have good outreach and good communication and good strategies to protect marginalized folks with our equity lens. So I just want to put that forward. I think what you'll see from Charlie's presentation is that we have a lot of good data to show that we can start to look at a new phase again of how we're addressing this virus and this disease in our community. So I hope that that paints the way for discussion around the public health order and other strategies that we know need to be in place in order to ease that order. And again, I'll just go back to the box it in strategy that we've discussed in the past, as well as this business and community social distancing checklist and protocol, consumer protection, we're calling it, to ensure that those things are in place for the long term, because we know that social distancing will be here for a while, regardless of all of our other strategies. So with that, I'll turn it over to Charlie and let him talk through the details of the data.
Thanks, Karen. Megan, you can go ahead and pull up the slides. And just in terms of background, I got into public health about the late 70s. I have a master's in public health and a master's in microbiology, both with an infectious disease and epidemiology track. A lot of the work I did early on was on Rocky Mountain spotted fever. But it was an interesting project because it was more endemic on Cape Cod in Massachusetts than it was here in the Rocky Mountains. So it was fun to spend time there. I did a lot in medical education over the years throughout my career, and then ended up here lately. Moved to the Valley 8 years ago, so I'm a relative newcomer compared to many of you. And my other company that I'm involved in, I do a lot of consulting for small businesses. So I'm very tuned in right now to the pain that they're feeling with a lot of the shutdown and in response to this virus. So my task today is to kind of walk you through Pickett County's criteria and supporting data for moving into our next phases of response to COVID-19. And I wanted to start off with a brief review of why suppression strategies work, and then we'll move into the evolving criteria and supporting data. Just in terms of a quick comment on modeling and data analysis, a lot of the data that we're looking at, we'll have actual data to support our decision-making, but modeling is used to support decision-making when we're uncertain of the data, or when we don't even have data in certain areas. So the models are idealized situations. One of the more intellectual questions in microbiology is, are viruses alive? You know, if you want some interesting reading, you know, try Googling that and looking at the arguments on both sides. The SARS coronavirus 2 particle has a diameter of about 120 nanometers with a strand of RNA surrounded by protein and lipid layers. To give you an idea of the size, there are 25,400,000 nanometers in an inch. So if you divide that by 120 nanometers, if you put viral particles side by side, there are 212,000 viral particles in 1 inch. So they're kind of tiny little guys. And that has repercussions when you talk about face masks and things like that, and you know, filtering out those viral particles. If a viral particle was sitting on the desk in front of you and you did nothing, it would just desiccate and fall apart eventually. It cannot reproduce on its own. Its lipid coat is key because it makes it, if you run your hand over a surface, it's more likely to adhere to your fingers or your hand than it is to the surface that of a countertop or something like that. So that's why washing your hands and wiping down surfaces is so important. And unless you pick it up and actually introduce it into your body, touch your eye or your mouth, it cannot reproduce on its own. It has to be in a host cell. So that's why not touching your face is so important. And of course, it can be inhaled in certain instances, such as someone coughing or sneezing in your face, which is why wearing masks and social distancing is so important. And finally, if you picture a map of Pitkin County and put a dot, everybody who's appropriately isolating at home, and then the next morning put those dots into motion, they end up congregating in certain areas, certain nodes. And that might be City Market, the post office, Whole Foods, pharmacies, places like that, which is areas where viral transmission can happen, which is why our stay-at-home orders have been so important in preventing viral transmission. Next slide. Megan, oh, there you go. So all of these strategies together are aimed at interrupting viral transmission. And as epidemiologists, we look at a reproducibility number called R0 of various pathogens. And to give you an idea, the R0 of influenza is about 1.1 to 1.4, which differs from like the measles virus, which is 12 to 18. So you can see how a measles outbreak could really expand very quickly. Our studies have shown that the R0 of the SARS coronavirus 2 is between 2.0 and 2.5. So the chart here, it kind of illustrates one infection can lead to 2, which leads to 4, 8, 16. So in just 4 generations, you can go from 1 to 16 infections. If we can reduce that R0 number to 1 or less than 1, then it goes from 1 person to 1 person to 1 person to 1 person. And by the 4th generation, you still only have 1 infection. Next slide. So that in the way of background, the first criteria for easing suppression strategies is a decrease in cases over at least the last 14 days. So we can look at, if we had PCR testing that on everybody, we can look at how our cases are progressing. But in our case, especially looking retrospectively, we have to look at proxy measurements like new cases in healthcare workers and hospital admissions. But going forward, we're focusing on PCR testing for everyone that's symptomatic through AVH and our primary care physicians. So we do expect to see reported cases rise because of that, just because we're actually doing the testing. One of our hedges in looking at that data is going to be continuing to look at our community symptom tracker. So we could actually get information on what's happening at the community level, just in reporting any types of influenza-like symptoms. We'll also be monitoring AVH and VVH COVID hospital admissions. And we'll review and compare testing and symptom tracking from adjacent counties and the state. And then finally, we're going to try and put in place some tracking by occupation so that as we open up various segments of our community, we can look at those cases within those specific occupations. Next slide. So here's a picture of our actual community tracker data. And if you look at it, our peak in onset of influenza-like illnesses was in mid-March. Because we didn't have a lot of confirmed testing for cases, you could see that next line right below it is the confirmed cases, but it kind of parallels, you know, what the community tracker showed. And then the bottom line adds probable cases just based on the history of the patient. So we're collecting this information on an ongoing basis, and we'll be able to see any spike in the data. And we're also collecting similar data from Garfield County and the Roaring Fork section of Eagle County so that we can kind of continue to monitor people's movements through those areas as well. Next slide. So this is data actually of AVH hospital admissions. And over the course of time, even since March 9th, they've been averaging less than 1 per day. 2 were transferred to a higher level of care at a lower elevation from the ICU, and 2 were transferred from the emergency department. So we're kind of, there's no real big spike. The range of these is 1, 2, and 3 per day. We've never had really challenged our AVH's capacity. And we're also watching this kind of data from Valley View and other Colorado hospitals as well. So retrospectively, we have our symptom tracker and hospital admission data, which tells us that we flattened the curve, and going forward, we will actually have PCR test results for symptomatic patients. Next slide. The second criteria is to look at our health system capacity, and then it's ready to handle any surge in cases, and current hospitalizations are stable. And right now we've never, like I said, we've never really challenged AVH's capacity to any degree, but in advance of a potential surge, they've done a lot of great planning, which I think is a testament to our IMT, Dave Ressler and his team, and to cooperation of all the regional hospitals to put in place plans to handle any kind of surge that might come forward. Next slide. Megan? One back, went too far. There you go. Now one more. There should be one in between. The third criteria is that testing can be performed on all patients. There we go. So where do we stand there? AVH is now focused on providing community testing, PCR testing, and some of our PCPs, our primary care physicians, are also providing PCR testing. And our objective is to test all identified symptomatic individuals and their contacts. As some of us, some were talking even before we got started this morning, we also need to keep in mind that testing and the associated PPE capacity is going to be stretched in the future. As construction and businesses open up and their workforce returns from Garfield and Eagle counties, as professional and service offices open and our population starts to spend more time outside and potentially down valley. Ultimately, as wedding, events, tourism, and lodging opens, visitors might come in from endemic areas. And as schools open, both parents and kids will face increased exposure. So these are all going to have an impact on our ability and how many tests we need to be able to do on a daily or monthly basis. There really hasn't been much guidance, for communities in terms of per capita testing capability or capacity. Yesterday, at the federal level, they announced that we got to have at least 2%, be able to test 2% of your population per month. And, I think that's a very, very low number compared to what we're going to need to be able to do going forward. We've been able to stretch our capacity a bit by using private labs. The state lab says they're going to have a better turnaround. We started testing on Friday, and right now we have 18 pending and no results back from the lab yet. So it would be great if we could move to a point where we could do testing within hours, but we're not there yet. We're going to have to continue to rely on private labs, at least for now. Next slide. So this is just a quick breakdown of occupations as reported in census data. And we're going to be drilling down on this in terms of our monitoring going forward. So for example, in the construction industry, it shows about 6% of Pitkin County's population reported being in the construction occupation. That doesn't take into account all the people that live in Garfield and Eagle County and come up to Pitkin County. So we'll be having to look at monitoring programs that will know the number of people here, but we're going to also have to look at and cooperate with Garfield County and Eagle County on monitoring that labor force moving back and forth as well. Next slide. So epidemiologists use a model that, and this is just a standard model. It's called a compartment model that uses differential equations to mathematically model infectious disease outbreaks. And they're pretty idealized. You might have seen these from some of the state reporting. If you look at the blue line that starts up in the top left corner, that compartment is our susceptible population. And it declines at a typical epidemic as infections and people who are exposed end up as more infections, and the red line then increases and goes up into the top right area. And those are people who are now immune or die or otherwise leave the population. So unfortunately, our model for Pitkin County looks quite a bit different. Go ahead to the next slide. If you remember back to what was going on at the end of February, beginning of March, which seems like a lifetime ago rather than just 2 months, on March 8th, we received our notice of our first case. Progressive public health orders, March 13th, 18th, and 23rd recommended social distancing, closing ski areas, schools, restaurants, businesses, and advised residents to stay home. And it also advised visitors to leave town and go shelter in place at their home. I think John mentioned before we started that the population of Aspen and Pitkin County can actually go up to 50,000, when we're full, completely full. I used a smaller number, it doesn't really matter the number, but our population dropped down to our resident population, which is about 18,000. So this model reflects that drop in susceptibles, not due to infection and recovery or death, but to actually leaving town. And with them went possibly exposed and infectious individuals in addition to susceptibles. So the takeaway from the graph or this model is that a large segment of our population remains susceptible. And I think this is consistent with state data and even national data. As many infections as there's been in certain areas, there's still a large percentage of our population that is susceptible, which favors kind of a conservative approach going forward. Next slide. What we don't know, and what we'd really like to know, is the absolute number of cases that we've experienced here in Pitkin County. And we don't know that because there's been a lack of PCR testing to confirm infections, which is a whole different story that starts at CDC and works its way down. The guidance for symptomatic patients was to stay home and recover at home if possible because of those testing limitations and the lack of antiviral treatment anyway, unless they were very sick. And protective PPE gear was in short supply. So as you can imagine, with surges being experienced in areas like New York City, which is close to my heart because I have a son who and his wife who are hunkered down in an apartment there. Pitkin County is not at the head of the supply chain when it comes to test kits and PPE. So go on to the next slide. We have to look at data that we do know. We don't know the total number of tests as confirmed by PCR. We do know the number of Aspen Valley Hospital patients tested. We know the positivity rates of those tested. We know the number of patients who've been intubated and transferred. So between March 9th and April 24th, 37 patients at AVH, and this is data as of Friday, those numbers have gone up since then, but as of Friday, 13 were positive, 22 were negative, and 2 were pending. So you have to keep in mind that those 37 patients had influenza-like illness. They were not a random sampling of our community, but you can look at the positivity rate there of people who reported with symptoms. We also tested 6 healthcare workers at the hospital. 2 were positive, 4 were negative. And of the 25 admissions, 22 were discharged, 2 were intubated and transferred. One's at the time on Friday, one was still in the PCU. As of today, there are none. There were no deaths at AVH, 2 deaths in our community, sadly, and 2 additional intubated and transferred from the ED. Next slide. Next slide, Megan. There you go. So from hospital admissions, that's one of the hard numbers we have. We can kind of look at it and inferring what the cases are in Pitkin County. If you look at Colorado data, and this was again as of Friday, 2,237 people were hospitalized, or 20% of cases required hospitalization. Just using that number, that would say we'd had about 135 cases in Colorado, in Pitkin County. The problem is that some cases requiring hospitalization left Pitkin County. We know that early on when the big group all of the visitors left. We did learn, sadly, that one case of a gentleman that returned to Australia and reported being in Aspen at the time of the reported cases did pass away. So we actually have lost to follow up a lot of those people that were here. And if you think about those people, those were the people that were at the belly up. They were at the, at after après ski parties. They were in ski school. There was They were the ones that had a lot of contact and then they left town. So our denominator in number of cases is probably much higher. If we look at international data, hospitalizations have been reported as low as 4%. And if we apply that to our hospital admissions, that would mean our cases are closer to 700. And you may be seeing in the news and in literature now that Los Angeles and Santa Clara, California, have done some sero surveys, and New York as well. But in California, both of them had fairly similar numbers, that about 2.8% of their population were previously exposed or have detectable antibodies using their test. And that would equate to about 504 cases in our county. So we have to be cautious a little bit, because the virus doesn't spread homogeneously. It spreads differently in an area like New York City or San Francisco or Silicon Valley versus a rural county like Pickens County. It spreads in dense urban areas differently. And their studies may also be a bit flawed, depending on the tests they use, whether it had false positives. In Santa Clara, for example, they used Facebook to recruit patients or participants. So people that thought they might have it or wanted to know whether they have it signed up. So it may not have been exactly a randomized sampling of their population. But for epi purposes, I think we can use a range of somewhere of 500 to 700 cases being here in Pickens County. Next slide. Megan, next slide. Too far, one more back. What I want to do is go back and look at our SEER model. Can you go back one, Megan? There we go. Which we looked at previously. So even absent an exact count, we are confident that based on hospitalization rates, that we were successful in flattening the curve, but this success means our susceptible compartment is still the majority of our population. Again, whether we use 500, 700, or even 1,000 cases, you subtract that from 18,000, that means that the majority of our population is still susceptible, which means that our physicians will still treat each case of influenza-like illness as if it was COVID-19 until proven otherwise. Our residents should continue to practice hand washing, covering their face in public, social distancing, staying at home when they're sick, and getting tested immediately if they have symptoms. And our public health approach should continue to be conservative, data-driven, protective of public health, and planning for capacity to handle any surge in cases. Next slide. Next slide.
Sorry, Charlie, if you could just bear with us for one moment. We're having some technical difficulties and I'm
no worries.
okay. We'll make sure we get all this troubleshooted for our next meeting.
I'll go ahead and keep going while they're doing that. The fourth criteria is that we need to actively isolate and quarantine contacts. And we're ramping up our army of investigators and contact tracers by currently focusing on training and streamlining our processes for efficient follow-up and of isolation and quarantine individuals. Just like the hospital continues to prepare for a surge in cases, public health is building up its infrastructure as well. And I think this timing that we've put in place now to extend the public health order until May 8th is going to be important timing to allow for that infrastructure to be built up. Finally, the fifth criteria is maintaining communication to the public and employers of the importance of social distancing and reporting all symptomatic individuals for testing, and putting indirect and direct enforcement in place, which is being discussed at all levels. And finally, we should recognize the continuing need to protect our aged population with those with underlying medical conditions, our populations most at risk. If you could see this slide, you would see a graph of the population age breakdown for Pitkin County. 41% of our population is 50 and over. 26% is 60 and over. So what's the risk to those groups looking at statewide data? And if you could see this graph, you would see that 50% of cases in Colorado are 50 and over, but 95.4% of deaths in Colorado are in the 50 and over age group. That's an important number, I think, for us to, okay, we're getting there. That's the, go one more. There we go. Perfect. So you can see from this that 95%, if you add up the deaths in Colorado in the 50 and over age groups, are happening in those groups. 78% are in the 70 and over age groups. So these are the numbers we need to take to heart to make sure that as we open segments, we protect those age groups as much as possible with appropriate guidance. Next slide. Go back one. So go forward one. Okay. Protocols are in place, and our public challenge is to continue mitigation strategies, even while people are moving more freely about and working. The healthcare system strategy, our challenge is to continue to match capacity with need, and the public health challenge is the box it in strategy. There we go. Go one more now. So we are looking at data in our population through our emotional tracker survey as to how they're feeling about all of these hand washing, social distancing, staying at home type activities. And they're all rated somewhat or very easy by the majority, except disinfecting surfaces. And that's basically because they can't find the supplies on the shelves in the grocery stores because of panic buying, but the supply chain does seem to be catching up. So one of the things we'd like to add to this survey now going forward is some questions about whether we're going too fast or too slow, so that you get immediate some better feedback on a weekly basis of, as we start ratcheting things up, you know, how the community's feeling about those activities. Next slide. We do know that the current plan is sound, but also realize the cost of current suppression strategies are high, both in terms of economic and personal hardship. So we need to find a way to live with COVID-19 for likely some extended period of time, since antiviral therapies are not perfected yet, and we don't have a vaccine yet. And that vaccine development, it has to be developed, safety tested, manufactured, and distributed worldwide. Until then, we have to make decisions locally about the pace and best approach to reopening certain businesses and activities to protect our community's overall well-being. Next slide. Just two more quick things. I want to kind of give you a case for gradual easing that kind of relates to some of the consulting work that I do now with small businesses. There's be a tremendous time, financial, and emotional cost to restarting a business, a school, or organization. If you think about a restaurant owner that will need to rehire laid off workers, invest in restocking perishable inventory, invest in advertising to open up and get back to full capacity, and then they're told they have to shut down again. They may not have the resources to do that more than once or twice. The pain of waiting a bit longer to restart may be less than the start, stop, restart type scenario. We will have to make it clear to them that the risk of reopening now, that there is risk of reopening now, and that if cases surge beyond a certain point, further suppression might be needed. But I think that's important for us to keep in mind, that this is going to be difficult for people, not just, even though they're anxious to reopen, we want to make sure the timing is right. Next slide. So this is the last one here. You know, we've survived other viruses with higher R0s, with higher case fatality ratios, like polio and smallpox, and the 1918 influenza pandemic. The shortest path to reducing our susceptible population for this virus may be an effective vaccine that confers immunity. But until then, the most logical path may be to carefully and slowly allow our population to move about and return to work, accompanied by monitoring, collecting data, testing, isolating and quarantining, and protecting our most vulnerable. So if you have any questions, I'd be happy to answer them now, or I'd be happy, you know, if any of you have questions anytime, you can email me at charlie.spickert@pickenscounty.com or give me a call, and I'd be happy to talk to any of you if you have any questions. Tom?
Do you predict the date of a case, the date that you actually test or have the patient in the hospital, or when they say the onset of symptoms began?
In which chart?
In the chart that you showed the AVH cases.
Those are hospital admission dates.
Thank you.
Mm-hmm. If there's nothing else, I'll turn it back to you, Marky.
Thank you very, very much, Charlie. That was extremely informative. Charlie, I know you're watching data from all over the United States. And we also were talking earlier that we are seeing some of our part-time homeowners come back here. And while you were presenting, my neighbor from Texas just happened, I was listening to her message, and it's one of those where Texas is opening everything and she's afraid, and she's 85 and she wants to come back to Snowmass. That's going to be a tough call. And I think we're seeing more and more and more of as part-time homeowners come back. Can you opine on what you're seeing in the Texas, Georgia, South Carolina a little bit?
You know, it's different in all of those areas. You know, it's you know, we have an airport, and people are going to be able to fly in, and we won't know their origination. You know, whether they originated in New York or Texas, or you know, because they may fly through Denver before they even get to Aspen Airport. So I think having the kind of order that you guidance that you currently have in place, that people should quarantine for 14 days is important, particularly now. Eventually, you know, we'll be able to track cases, and if people report symptoms, be able to isolate and quarantine them directly. But you know, short of putting a lockdown on Pickens County, you know, it's going to be difficult to prevent them from coming in.
Yeah, it's very, very hard. And the construction industry is now open. I'd be helped to know how that's getting monitored, and perhaps that's a Peacock question. Yeah, I was up at a couple of sites yesterday and talking with John last evening. I already found one site non-compliant. So how are we monitoring that, John?
Yeah, thanks, Marky. So each of our community development departments have taken on responsibility for reviewing COVID-19 plans. I know for the county, we'll be doing spot checks with our code enforcement officer. I know each municipality had plans to also be doing spot checks. I expect as we ramp up, Marky, we'll probably see more examples, and then through the spot checks and ongoing education, we'll see higher compliance.
Thank you. I see Greg's hand. And then
Hi, question for Charlie. Sorry, Brent, I think I may have gotten it in front of you. You've got one too. Brent's, Charlie, if I'm just wondering, you know, we always hear in the media about various, you know, apps for contact tracing. What's happening in the various countries in Europe, you know, how things are working in Singapore or Korea or Italy or, you know, Sweden for that matter. Mm-hmm. And I'm just wondering, are you monitoring, you know, what's happening elsewhere, and are there any models of things that we might do here, or if there are and we're not doing them, why wouldn't we be? Are there statutory regulations that make things different in the US? And just kind of wondering, some countries seem to be incredibly progressive or proactive, and it could be due to their governmental makeup. So it's interesting to see that from here and wonder why we're not doing it or why it wouldn't work here.
It is starting. You know, Google and Apple are, you might have read, are collaborating now on cell phone monitoring and trying to do that in an anonymous way to some degree, to show how populations of people are coming together, where those interactions would take place, and maybe if people opt in, be able to learn about an exposure they may have had. We've started to look at some of those, excuse me, but you know, there's obviously equity issues. Not everybody has a smartphone. So we want to make sure that the monitoring programs that we put in place reach all segments of our population, not just those that have high-tech capabilities.
And Greg, I would jump in also. I know our IT department has been keeping abreast of options and also stands ready to support public health. It's a little bit like everything with this pandemic. It is a rapidly evolving field. And I think, as you pointed out, there are unique values that we need to recognize, whether they be privacy concerns and such, that make what we can do here different than what maybe is being done in some other countries. But the infrastructure is there. The core thing that needs to be done is to build these teams so that we have, because this is, even with technology, this is a people-powered endeavor. And then to build that infrastructure to make the teams as efficient as possible.
Mm-hmm.
Brent, you had.
You made us just a couple real quick things. In terms of those apps that are being used internationally, from what I gather, even a 50% compliance is viewed as a win. So whatever of these contact tracing type apps, Bluetooth, they can be essentially voluntary or can be completely voluntary. But if we get even close to 50%, it gives you, from, say, as I understand it, from an epidemiological standpoint, some pretty good data. That was one comment I had. Another comment was that seems to me that we really need to stress this mask wearing and social distancing. That's something, because especially with an influx of people, we're going to have people that you know, want to, I want not disobey, but act a little bit less conservatively than they should. And I think, you know, that would be an important thing for the public to have a kind of a constant awareness of how important that the mask wearing and distancing is. And the third thing, just really quick, and this I address to Kim and Tom and whoever else, the doctors, is that from what I have read, that the whole business of staying at home, monitoring your temperature, and then when you have symptoms sufficient to go to the hospital, I've read that that's completely wrong, that was designed to keep the hospitals from being overloaded. But that now that they realize, because of the eccentricities of this disease, and especially this thing they call silent hypoxia, that you can have blood levels. They've even seen people talking on a cell phone as they walk into the hospital, and 8 hours later, they're in the ventilator. And the point being that the remdesivir and these other interventions, and even perhaps just getting early oxygen, keeps this thing from getting worse. So that really you want treatment early on for this potential pneumonia that you may have. And they're talking about having people have their own oximeters and so forth and so on. Anyway, that's all I wanted to say.
I don't know. Kim, do you want to talk?
Yeah, sure. First of all, I just wanted to also thank you so much, Charlie, for going through that. That was really helpful. And on an ongoing basis to have these numbers kind of put into the whole public health direction here is essential. Can you tell us where, I just want to make sure how we can access this recording to share with others, and then I'll address what Brent had said.
Mm-hmm.
I can answer that question, Charlie. So our liaisons team will be posting a recording of this on our website, and we'll make sure that that goes out to
So Pitkin County Public Health website?
pitkincounty.com/COVID.
That's where it will be posted. Okay, great. Thank you. Yeah, so Brent, I think that silent hypoxia is something that we have seen. The truth is that a little over 80% of people have mild symptoms. It's such an unusual virus that these 80% or so people that can manage it at home need to stay at home. And that's what the message has always been. Now there's the other percentage, and some of them are the vulnerable population, which clearly, as Charlie showed, that the over 70 and especially over 80 are very susceptible to severe disease and need hospital care. And people are, and AVH has consistently urged people that if you feel that you need the emergency room, you need to come. We're open for business. We want to help you. And that is the message to that smaller percentage. Now, the solution to the in-between, the moderate, is the tent outside. And so we have always urged patients to talk to their doctor. And if they're having any type of issues managing at home, that tent is a place to that a patient can be evaluated and get their oxygen checked, because that is essential. And we have seen the silent hypoxia, and that tent is kind of the solution to keeping people out of the emergency department who don't need to be in there, because it is actually a high-risk place for a patient to be. And the tent outside is a great solution for patients to get their oxygen saturation checked to make sure they don't have that silent hypoxia. And that tent has been used, and it's there, and it's in operation, and you do need to have a physician referral to it. And if you don't have a primary care physician, the solution was the AVH Primary Care Center, where anyone can call in if you don't have a doctor and say, hey, I'm having problems. They'll do a quick evaluation, see if you need a tent visit, and then check your oxygen saturation. And so I think it's a great point. But again, the 80+% that have mild symptoms at home and do just fine, and some of them just lose their sense of smell, and that's it. We don't want to overwhelm the healthcare system for that, but we do want to take care of people that need to need to see a doctor. Does that help out?
No, I was just wondering whether these events of the last few weeks have changed that kind of triage, and perhaps not really. That it works fine. Thanks.
I think that triage is in place and should work very well as long as people reach out to their physician or reach out to AVH if they're having any difficulty at home, or they feel like they're having any difficulty problem breathing, and they can access the system that way. And of course, the ER is always open if anyone ever feels like they need emergency care.
I have a question, and probably this is going to go to John, and then I'll call on Tom. John, since the airport is under your auspices, do we do any tracing or thermal scans when people come through our airport?
Yeah, so right now, Marky, we are set up to capture everyone and make sure they have our quarantine and public health information. The airport is looking at those types of technologies, and I think that goes back to some of the earlier conversations when Charlie was talking about the different industry sectors and such. We're going to need to spend some time really understanding what works in terms of airport screening. I know temperature screening is something that was done. What we are not clear on until we have a little bit more capacity to look at from a public health perspective is, so was it effective? Did it decrease risk or actually increase risk because of the way it was done? So we are, I have airport staff looking at those options and also consulting with the FAA on any forthcoming guidance that they may have. And we would anticipate that as we build our public health capacity, we'll need to bring some of that subject matter expertise to the table. I think it's important for everyone to understand that basically nationwide, air travel is down over 90%. And it's even more so here. We are not seeing airlines planning to return significant capacity really through the summer. We are seeing some flights being added for June right now, but May we're going to stay at a very, very low level. I think June is going to depend very much on what happens with our conversation on Thursday and how we step in to different levels of activity in the community. People come here because of what they can do here, not to fly on the airplane. And so as we continue to restrict activities, we will see lower levels of activity at the airport. So I think we've got some time to figure those mechanisms out.
Thank you very much. Tom, you had your hand up.
Yes, I would like to compliment Charlie on his superb presentation, and first go to John's point, because I was on the ASC committee months ago, that you take advantage of the airport informational people to educate the population of passengers as they come in as to what they need to do to recognize symptoms, and so any cases can be properly identified and quarantined. The second thing is, I'd like to ask, with Gabe Muthing doing testing in the community, do we know what results that he has at this point and how that can be utilized for attaching to additional cases that might be identified at the present time? And lastly, I really think that the population that we have at the present time is going to be viewed in a different way as to what happens with the events. And I'm on the Wheeler board where we have Justin Brown from the Music Festival, who described to us at our last board meeting last week that on May the 15th, they're going to make a decision as to what they're going to be doing for the rest of the summer. So if you look at that date with the music festival and communicate with him, you might use that as a kind of a point or date that you work around. I'm finished.
Suzuho or Karen, do you have that information from the question about what Gabe has in terms of data?
So Tom, just for clarification, are you talking about the ABH PCR testing that got ramped up on Friday?
Tom, is that what you're interested in?
Yes, and a possible expansion of that with the test being validated.
Yeah, so the PCR testing that ABH started to expand on Friday, we haven't got the results back. That was, Charlie was referring to, I think the 18 pending that we haven't seen. So that's, we don't have those results back yet.
And can I make a comment, Tom? I think you may be possibly referring to the antibody test that the county and Gabe were moving forward with, and the decision has been made. My understanding, the decision has been made not to use those at this point because they are not, first of all, the A2 company where they got from does not have emergency use authorization yet from the FDA. The test results will not be able to be useful in terms of any positive results, and it was very unsure as to how to use an antibody test in terms of its usefulness and value going forward. And this has been across the nation. There's been a lot of conversation about how the antibody test, which gives us past results, prior illness instead of ongoing illness. So the decision was made, and I think it was very well decided that the PCR test, which tracks active illness, is the way to move forward. And so ABH has put in there's a second tent now in front of the hospital that there's going to be a lot more use there, and a very streamlined process in terms of getting people in as soon as possible, as soon as they start getting symptoms, so that we can quickly identify a new active case. And public health can then start the box it in strategy as soon as possible. And that is the strategy moving forward.
Yeah, and just to add to what Kim said, the A2 test had an emergency authorization for distribution, but not emergency authorization for use. And in those fast moving early days, when it was very unclear about what tests were going to be available, we did we did acquire these tests as soon as they received their emergency authorization for distribution. We had done that with the best information we could at the time and understanding PPE and actually working with physicians at the hospital. But as more information came out, as Kim said, about some of the specificity issues with a number of antibody tests in particular, we thought it best to hold on using those tests or making a decision to use those tests until we had more clarity from the FDA, about the accuracy and hopefully they would get their emergency use authorization and we would have better information. But with the ability of the hospital to ramp up PCR testing, as Kim said, that was clearly the direction to go, and it informs the box it in strategy in a way the serology test doesn't. So if that does get emergency use authorization, Dr. Kerr, we may revisit, if and how we want to use those serology tests in the future.
I was just checking because there are many tests that are now approved. If you go to the FDA website under CDRH or the Center for Devices and Radiologic Health. So there are other options, and I just wanted to be sure those other options and other companies are being taken in account.
Yeah.
So-
Oh, sorry, Kim. I was probably
Oh, go
going to
ahead.
say the same thing you were, which is we're in a partnership with AVH and medical staff at the hospital, really watching all of these tests. Last I saw Dr. Levin, I think we had analyzed 18 or 20 of the tests, and now it keeps changing. So that's to say we are keeping abreast, and there's also still supply challenges with some of them, even though they're approved.
I agree. Yes. And we do have a whole testing committee at the hospital that actively looks into every option. And again, there's the difference between the PCR test, which shows new active cases, and the antibody test, which shows that you had it in the past. And so we are really actively looking at any type of testing for new active cases. The PCR test is the best one at this point. Things may change, and there are always new tests coming down, being produced every day, and they're actively looking at every option. In terms of the antibody test and its lack of sensitivity and the false positives that it may have, it really, and this was a national conversation in terms of antibody tests, and I think the county did the right decision not to use them at this point, is that it will not guide, it doesn't have any value in guiding a person in their behavior. It has no value in terms of saying, hey, you're okay to go back to work, or hey, you're not okay. The positives and the negatives are, the test itself doesn't have the efficacy, and it doesn't drive any policy or changes in behavior or the ability to open up at all. And so there were very confusing messages. And the only reason I can see possibly even using it at this point would be looking at an epidemiological look at what percentage of our population has this, without actually giving people test results, because the test result doesn't guide them in any way. However, the PCR test, which looks at new cases, is extremely usable and vital to what we are putting into public health at this point. And so AVH has done that, set up that testing site, and that's how we'll move forward.
Right, there is also an art to properly obtaining the PCR nasal swab testing that I learned years ago. You really have to put that swab all the way back. And so the New York population that was recently, they counted the dead and the number that had positive nasal swab tests, and it was less than half, surprisingly.
Yes, that is true. And it's uncomfortable. And we have very skilled people at AVH who have a lot of experience in doing this test. And again, there are a lot of different tests that are being produced now. You may have read about a saliva test or a swab in the mouth. And so our testing committee is actively looking at all of those options. And when a good option comes up, without compromising sensitivity and specificity, they may decide to move forward with that. And at this point, that uncomfortable nasal swab is the best option.
Greg, you had your hand up.
Yeah, thank you. I just wanted to thank you, Charlie and Kim, also just for the clarification, and Tom as well, on the testing, because as we all know, the community is clamoring for testing. They've heard there's testing going on it seems like everywhere but here. There's a lot of frustration surrounding it, and it's really important to have that message out. So everything we can do to get that message out is great. The question I had was, is there any value for epidemiological, documentation going forward to actually sample people and preserve those samples so we have an archaeological record of what was happening here? I'm just trying to think of a way we can engage the community and show them that we're being active on this, or demonstrate that if there's any value to it, because of course people want to be tested. It's just a broken record is what we're hearing. And the more information we get out about it, the better. But is there any other middle ground? Could we be doing sampling and preserving those samples with a date stamp? So perhaps we can go back and look at how this thing spread later. Is there any value to that? Or is it even affordable, something we could consider?
Telluride, you might have read about Telluride doing sampling their population with a full blood draw. And that would be the difficulty. The test that we acquired from A2 is only a finger stick. So you're not acquiring enough of a sample really to do any kind of retrospective study. You'd have to do a full blood draw, which would be expensive and require a lot of storage and other things. I don't know, Kim, do you want to comment on it?
Yeah, I mean, I think it sounds like a good idea. I think in practice, it doesn't make a lot of sense to be doing that in retrospect. The antibody test is, it's been looked at in so many different ways, and it's really doesn't have a lot of usefulness at this point. Again, I think the only usefulness might be if we use it on a widespread basis, but do not tell people their results, which is what people want. And we understand that, because it does not have any value in terms of what your result is. It doesn't help guide anyone in any direction. That's what we've discovered. And so it doesn't make a lot of sense. And I know the media, and there's been just such a huge conversation around the need for testing. We are actually providing the critical testing now that we absolutely need in this community. And at ABH, the new symptom and identification of new cases is the goal right now. And that is the most important thing in terms of looking at. I think Charlie did such a great job in terms of trying to estimate how many cases we may have here based on hospitalizations, and looking at percentage of hospitalizations in the state and in international data in LA. And I think that may be the best estimate that we have right now. That makes a lot of sense to look at it that way, that we may have anywhere from 135 to almost 700 cases. And if we just assume that, and I think moving forward, it makes a lot of sense to assume on a population of 18,000 that we have a very low rate. Our percentage is low. And so that means moving forward and using those conclusions moving forward in terms of, we need to open up very carefully and slowly, because we have a very low number of cases positives in our community. And I think it really helps guide that decision making right now. I think the antibody test unfortunately did not pan out, and John really mentioned, and this is true, the county was right on it, and this is so rapidly moving and developing that at this point it panned out not to be a useful test. And everyone wants testing, and I understand that. Unfortunately, it's not very useful, and maybe there will be antibody tests that are produced that are a lot more useful, but it's hard to, it was not, I think the decision made not to use them was very good, because it would confuse and send wrong messages to everybody and potentially send our community in the wrong direction, where I do think we're in the right direction now.
I just want to acknowledge our public health team was on top of, warning, frankly, me about acquisition of these tests. And I made the decision that when we had the opportunity, we should acquire the tests and take some of that risk, because there's so much uncertainty about that time, where testing capacity might come from. So it's really, public health understood this. I made a decision to take a risk, and we'll see if that pans out in the future or not. But right now, the best decision is to hold.
And if you
John,
think about it.
Wanted to say, I wanted to say I do support and appreciate your explaining this and the positions you've taken. I think, John, you made the appropriate call there. Kim, I hear it and I get it. And I think this is really the most important thing we can disseminate about the testing. It's not going to be it's not going to be really popular, but we all need to hear this.
And absolutely, everybody wants a test, and it's a nationwide issue. And if you think about the antibody test, if there are false positives and you get a test and you test positive, and then you're told, you know what, there's a maybe up to 30 or 40% chance that you're actually not positive or higher, what do you do with that information? And if you are positive and you feel, okay, that's a great test and that's a great result as an individual, I'm immune, now I can go out and start working, or I don't have to, I have immunity, so the social distancing doesn't apply to me as much, it's fine, I'm good to go. This is very dangerous, and I think could create a lot of danger in our community, because it's not it potentially is not a true positive, first of all, and second of all, we don't understand the immunity of this disease yet. There are some viruses that have immunity for years. There are other viruses that have immunity for 1 or 2 years. There's others for months, and then there's others that you can get reinfected in the same season. So this will pan out at some point where we'll get more information about the immunity. Does this virus, are we immune for life? Are we immune for a week? We have no idea. And so a positive result is only going to confuse everybody and potentially have danger to the community. And that's why. And if you really walk it through, and a negative result is not quite as dangerous, because you feel, okay, I didn't get it. I still need to adhere to the masks and the social distancing, and I'm not ready to go back to work. But that positive result is really a dangerous result and doesn't have any value. We can't guide anyone in what that result really means. And I think because of that, it was a great decision not to use the antibody test. And again, just go forward with identifying new cases as quickly as possible so we can contact trace, isolate, and quarantine, and really put out every little fire that comes up, and going forward, so that we can continue to open up and make steps to open up the community, because again, we can't stay in this suppressive mode. So we do need to move forward, and it does need to be done very carefully.
Are there other questions? Charlie, yesterday, I do have one. Trump was talking about 2% in terms of testing. What is your recommendation, particularly for our community?
A lot more than that.
That's what I thought. Yeah.
There isn't really good guidance for communities at this point, but one of the ways, as I mentioned, that we can hedge that is both acquiring test kits here locally, but using the state and private labs as well, so that we can test everybody that needs to be tested. In a small community like ours, like we saw in the initial phase, we will probably see clusters of cases that happen around, individuals traveling here, that will need a lot of contact tracing and testing. And then there might be periods where we wouldn't need as much testing. So, and we'll be looking for cases that are not related to that initial contact as well, so that, we know whether there's community spread or not. But 2% would be 500 cases a month, of tests a month. I think that's probably a lot less than we'll leave. We had 10 or 18 in the last couple of days.
Other questions? Tom, you're muted, and then Bill Madsen. Tom?
There you go. Nope.
You're muted. You're muted. Okay, Tom. Now you're muted again. Okay.
I'd like to suggest that you get in contact with Justin Brown, the general manager of the Aspen Music Festival, because if they go, they're going to have like 1,000 students coming in from various locations. And their opera people come in from Milan, La Scala, which is right in the middle of northern Italy. So how do you deal with that? I think he needs some advice quickly about how to deal with this if they decide to go, and how they should stage it.
Yeah, and Dr. Kurt, just so you know, I am in regular contact with Alan Fletcher on a weekly basis. So they are aware of what we're looking at from a policy perspective and making decisions based on that. So I'll be sure, I'll be on a call again this Wednesday. So we are in touch with the music school.
Thank
Excellent, excellent.
you. Bill Madsen, you had your hand up.
Yeah, just curious, based on the statistics and how the disease is targeting the older generation, as the Board of Health looks towards policies to slowly reopen, does it make sense to contemplate policies that are geared towards stay-at-home restrictions for the older generation as we look at ways to slowly reopen?
Absolutely. I think there should be guidance, at least for them, that to continue to shelter in place as much as possible. And I think John and his groups have looked at ways to help them provide groceries and other types of services so that they're not having to get out in the community as much and face that exposure.
Okay, good question, Bill. Do I see any other hands going up? If not, I'm gonna wait a minute here. Charlie, thank you. That was excellent. And I'm glad we're gonna have the slides available. And we look forward to you joining us again on Thursday for our board meeting. Okay.
Good.
Board meeting on Thursday, Suzuho or Karen, can you remind everyone of the time?
From 1:30 to 3 o'clock on Thursday. Just
Okay,
invite, and we'll have it public noticed in the next day or two, hopefully. Yeah,
and will you be sending out,
4 hours before.
okay, will you, Suzuho, send the CDPHE guidelines around COVID and various businesses, or should each one of us go on the website and pull it up?
Yeah, I'd say feel free to, browse CDPHE and CDC's website. A lot of our guidance is coming from them based on how all of that information flows, and anything related to the meeting on Thursday, we'll be sure to have links on the agenda that we'll send out once that's prepared.